Well, it's just a pleasure being here. And thanks to Chris and Teresa for asking me to come here. I'm so happy you did, because I just am so happy to have the opportunity to talk to all of you about something that is important to you and important to me and important to my organization, a nonprofit organization, Lower Extremity Amputation Prevention. We exist to partner with other groups like we're doing today to get very important information out to you, to help you avoid and prevent some of the terrible foot problems, some of them are terrible, to prevent some of the terrible foot problems that can be a consequence of diabetes. So the LEAP Alliance is a nonprofit organization which is partnered with the Las Vegas Summerlin Lions Club, a volunteer organization of many members looking for opportunities in the community to help anyone who needs help. We do lots of good things, and we have lots of members that help us do lots of good things, and we're always looking for new members to help us do good things. So it probably is not inappropriate of me to say that if after this talk we've coaxed some of you maybe to have an interest in being a Lions Club member and joining us in our community service work, I do have some information and applications and all that stuff. Come to one of our meetings, see what we do. We think you'll like us, and we sure will like you. But let's get back to the subject of feet. So here we are with a special focus on diabetes, with some time to talk about feet. Now, let me tell you a little story of why I'm here after having graduated. I know this will surprise you. I look like a very young man, and even to those viewing this through YouTube, they're going to be very surprised to hear, I'm sure, that I became a podiatrist in 1958. Now, that's a long time ago to have been treating feet and dealing with feet. And of course, now I am retired from practice, but still trying to work in the area of feet. So, when I was in practice, there probably wasn't a day, certainly not a week that went by, when some patient of mine asked me, "Dr. Rubin, why did you become a podiatrist?" So I said, "And doctor, would they ask me that question? If I was a heart doctor, would they ask me that question? If I was a stomach doctor, probably not." And I was constantly groping for something to say that would be short and sweet and kind of end that subject. And so usually what I said was, well, I chose a foot doctor after considering the many other organs that I might be focusing on, and some of them were just less desirable than the foot. And I didn't go into specific specialties, but I left that up to the person's imagination. They usually said, "I get what you mean." But it really does bring up the point that feet are kind of second-class citizens when compared to other organs of the body. We tend to think of the feet last, maybe because they're farthest away from our vision. And we close them up in shoes and socks or hose or whatever, and we don't think too much of them. Well, that may be okay for the average person, but it's certainly not okay for those of us with diabetes. We have to respect that foot, not treat it as a second-class citizen, for many reasons, One of the reasons is that, and I used to hear this from my patients, when your feet hurt, you hurt all over. Isn't that true?
Yeah.
You've heard that said. Your feet hurt, you hurt all over. And what do you do if your feet hurt? Well, you sure don't walk a lot, do you? And what do you need to stay healthy? The simplest thing that you need to stay healthy. You don't have to go to a gym. You don't have to work out with any particular system. But you do have to, if you want to stay healthy and do the simplest thing, walk. And if your feet hurt, you're going to be sitting more than walking. And of all the problems that come from sore feet, that's probably the greatest problem. Living a more sedentary, inactive life. Not a healthy thing to do for anyone, but especially when we have diabetes. And then sometimes we hear talking about feet being second-class citizens, some people just think it's normal for feet to hurt. It's normal for feet to hurt. I, as a new budding podiatrist way back there in the early 60s, used to have a feeling that, well, older people, kind of normal for things to start hurting. Now that I'm one of those older people, I don't think it's so normal. And it's not normal for feet to hurt. Here's an example of what happened one day that proved that to me. I don't know exactly how old Mary was. I think maybe my age, somewhere around 79. And she was in my podiatry chair. And she was explaining to me in detail, my foot hurts here, my left foot hurts here, my left foot hurts underneath there, my left foot really hurts. And I'm looking, and at that moment, maybe my mind wasn't as judiciously selective in the words that I would say, because I said to her, well, just as something to begin the discussion about what might be wrong with her foot, I said, well, you're, 79 years old now, but let's look into this. But, you're about 79 now. Kind of, the inference was what? Well, you're a little older, so maybe that's the part of the problem or the problem. But the answer that she gave me, Mary gave me a good answer. She says, Dr. Rubin, my other foot is just as old, and it does not hurt. Good one. So I remember that. And I tell you now, God bless Mary for having shown me that it's true, so I could tell you now, don't think it's normal for feet to hurt, and don't think that just because you might be a little older, that's normal in old age, because it's not. And most foot problems have relatively simple solutions. There's an awful lot of fear out of going to a podiatrist sometimes. My God, you walk into the podiatrist's office and you walk out and you walk out with a cast or surgery or this or that. And of course, that sometimes has to be, but most of the times there's lots of simpler, more conservative, easier ways to approach problems. And then if surgery is necessary, nowadays we have so many means to make surgery less traumatic and less disabling. So don't be afraid to have something done about your feet. Well, now, this talk really is going to be about prevention. And so as we get into that, and you did take your quiz so that you might know if there's some problem that you have. Well, maybe we can't prevent that particular problem that you've checked off here. And it's too late to prevent that, perhaps. Maybe treat it, yes, but not prevent it. But many, many foot problems in diabetics can lead to more serious complications. And those we can prevent. We can prevent the open ulcers. We can prevent the infections. We can prevent the amputations. By what? Paying attention to the warning signs, the symptoms, the problems that lead to these complications. So in diabetes, there's no such thing as a minor foot problem, and we'll go through the conditions that we see in diabetes, and you'll understand why. There's no such thing as a minor foot problem, because once there is a small minor foot problem, it's no longer minor. It is the beginning of a major foot problem unless we take precautions. So, I think you've heard that before. Those of you who are diabetic and the marvelous supporters of those of us that are diabetic have heard this before, that diabetics should definitely take care of their feet. You may not have heard that 80% of the serious complications that occur in diabetes, 80% can be prevented with an annual foot examination. An annual foot examination, thorough enough to find the problems that can, on the quiz, that can lead to trouble, and to do something about them to prevent them from leading to complications. Now, does every diabetic being cared for by a physician get a thorough, comprehensive foot examination? No. Is it the physician's fault? No, I'll answer that. Especially today. Now, we're talking about a thorough foot examination, which even in an experienced examiner's hands can take at least 10, 12 minutes or maybe longer, especially if there's discussions after the examination. Do today's physicians have the time or the energy to see the patients in the way we see them in today's healthcare climate and spend that amount of time giving you an exam? The answer is generally they don't. There are some that do, and we commend them. Now, podiatrists, of course, hey, that's what we do. But not everybody has their own personal podiatrist. Most of you depend on the doctor that's taking care of you, or the nurse practitioner, or the PA, or whoever it is. And at times they get rushed, and you may not get that examination that you need. And so, I tell you that is one of the things that the LEAP Alliance now offers, and that is free foot screening. Meaning that as we go through the conditions, as we will, on this list, and what they mean, if you feel that you need that more comprehensive exam, and any check saying, yes, I have it, really means you should have a foot examination, you will be able to have a free foot screening at one of several locations, and this is very new. I have a sheet that Arlene will be able to give you, or I will give you, that lists these locations right now. This is very new. We hope next year, if we come back or some other time, we'll have 24 locations. But you will be able to get a free examination, some advice, and hopefully some care. Then, at the end, if you have questions, I'll be happy to do my best to answer them. And we do have the ability to do one particular exam that's very important for those of you that want to stick around. So, the Foot Health Quiz, which you have all seen. Oh, I'm sorry. So you will be seeing that in a moment. Anybody else that has not seen it? Okay. If I have your quiz up here, that's fine. I'm just going to be going through the different sections. We ask a question. Are any of your toenails thick and discolored? Now, why would a toenail be thick and discolored? Let me give you the most common cause for thickened, discolored toenails. Now, you know, for every medical condition, there's probably a lot of different problems that might cause similar symptoms. People with psoriasis can develop thick, discolored nails. Tennis players who are very young and their foot's constantly slipping forward, short, abrupt, stop, dum, dum, nails get traumatized, injured. In time, they can become thick and discolored. So there's lots of different reasons why nails can be thick and discolored. The most common reason, especially after age 40, let's say, 45, the most common reason or cause is fungus infection. Now, fungi kind of are related to the mold on bread, or an orange that's left out, or whatever. But these fungi love feet and nails, because they can live in a dark environment, right? We put our feet into shoes and close them up or whatever. And so these fungi can attack the nail, and first what happens is, it looks like a yellow streak or a brownish streak. What's that on my toe? Next time you look at the nail, maybe a month or so later very closely, and you see that the whole nail is discolored. And as time goes by, it may get thicker. The odds are, because this is kind of a random sampling of diabetic patients that have come into this room, So we might statistically say you're a random sampling. And kind of an age over 45 is generally the prevailing age group, right? We could say about 30% of you have at least one toenail that's infected with fungus, maybe more. Those are just statistics. Now sometimes we don't do anything about it because fungus nails, unless they get so thick and the shoe hurts them, fungus nails don't really hurt. But those fungi, or fungi, depends on what part of the country you come from, those fungi that are infecting and digesting the nail live in the skin below it as well. And your body, your system, is trying to get rid of it. Actually, we could take serum, blood serum from a person with, the technical name is onychomycosis, fungus infection of the nail. We could take blood serum, and they have identified antibodies against the common fungi. Your body's trying to get rid of it, but it can't because the fungi are embedded in the nail, and even with some superficial medication, they just persist and resist milder forms of treatment. But it's important that we get rid of fungi. Why? They're contagious, number one. Forget about grandchildren, other people who might walk where you walk or whatever, it might spread to them. That's true. They're contagious, but they spread to other areas of the body. In other words, if the feet are infected with fungi, we might next find infection in the armpits or other parts of the body. Fingernails very commonly get the infection after the feet are infected. So we say, don't live with fungus infection of the nails, especially if you're diabetic, because there's a good chance in diabetes that your feeling is not absolutely normal. We'll talk about that. Your sensation is not normal. And that thickening underneath causes pressure, and we see ulcers and sores occurring beneath mycotic nails. We don't want that first sore or ulcer to open. So if you have checked that you have thick and discolored nails, or even one, let's make sure that it isn't fungus. And if it is fungus, there are many ways of treating fungal infections that are very effective. And most all of them do not necessitate terrible pulling out. I've heard these horror stories that people tell me. I don't know where the treatment is coming from, but certainly nobody I know would treat toenails by painfully pulling them out or all this. No, there are very much simpler ways of treating fungal nails. Make sure that if you think you have one, you get an examination and a suggestion as how it should be treated. There's a lot of over-the-counter preparations. There's a lot of claims you see on TV. The infection is underneath the nail as well as in the nail. These preparations, once the infection actually is deeply embedded, you have to get beneath the nail with medication, and that's either going to be with internally medicine that's taken by a pill or tablet form, or by painlessly getting rid of enough of the infected nail so the medication can be applied topically. And I say painlessly. We call it nail debridement, and nail debridement is not painful. So the only way you really can get rid of fungus infections of the foot, of the toenails of the foot, is to have the proper treatment. These over-the-counter preparations, I'll be honest with you, including Vicks salve, I don't know where that came from, but you've heard, I think Oprah mentioned that once. They're just notoriously ineffective. So, toenails. If you have more questions, if you have any questions about that, we can talk about that. Does your heel hurt when you step out of bed in the morning? Anybody here ever had that? Everything's fine, get out of bed in the morning, step on your foot, and your heel hurts. Well, I'm glad none of you have had that. But you may know somebody that tells you, I get out of bed in the morning, I start my day with my heel hurting. Well, that's usually, again, everything we have to say is an educated guess. We don't have an X-ray machine, to look at, and I'm talking kind of off the cuff of generalities. But when people get out of the bed in the morning and they step on their heel and it hurts, it's usually plantar fasciitis. There's a broad ligament on the bottom of the foot. It's like a bowstring on the bottom surface. It goes from the heel bone to just behind the toes. It's like a bowstring. And when we step on our feet, it stretches. And that kind of gives us some cushioning to each step. But in some people, that constant stretching pulls where that fascia is attached at the heel. And that constant pulling can inflame the area. So it gets inflamed. What's inflammation? It's the accumulation of a lot of blood in the area, trying to get rid of some problem. In this case, an injury, just the fascia, little minute tears actually from stretching. But the blood supply, the inflammation, the blood that comes from the inflammation can't really heal that very well or very fast. All night long, it's engorged with blood trying to heal it, and then in the morning, you step on the heel, and that is actually deep, in the deep areas of the heel, by the fascia, actually swollen deeply. So you're stepping on a swollen area until we really, the word is extravasate, until the blood in that inflamed area kind of dissipates. It's going to be painful. So, I'm glad none of you have that, but now you're at ADPM after your name. I have, after my name, is Lawrence Rubin, DPM, Doctor of Podiatric Medicine. You can put ADPM. That means almost a Doctor of Podiatric Medicine when it comes to morning heel pain. And thick nails? Okay, two almost DPM qualifications. Wait, it's time to get out of here. We should give you a certificate or something that makes you a foot health educator. And I think that wouldn't be a bad idea. You're going to have people complaining about their feet. Maybe give them this quiz and help us along. Number 3, do your toes cramp and become painful when walking? Okay, it's kind of a tricky question. I used to teach years back in the College of Podiatric Medicine. My students used to always tell me, you give the trickiest tests, but we learn a lot. So that's okay. It's a tricky question. Do your toes cramp and become painful when walking? It's tricky only in the sense that we don't expect an answer from the men. Don't expect it. At some time or another, maybe women in the audience, maybe your toes have cramped. For example, you have a shoe that maybe isn't as roomy as it should be. You're walking along, maybe you're in the shopping mall, and suddenly this sharp pain feels like it's in the ball of the foot, and what do? You take off your shoe and you rub the area until it feels better. Well, that is due, if any of you have, women in particular have that, that's due to a benign reactive tumor called a Morton's neuroma or neurofibroma. It's benign, and we say it's reactive. Why is it reactive? Well, there are nerves that go down, the leg into the foot and then into the toes, but they go between the metatarsal bones, and just like on the hand, just behind the fingers, the metacarpal bones. Picture these nerves being deep between the fingers, behind the fingers. When shoes squeeze and press constantly, day after day, especially a woman that's in a high-fashion shoe, or even a woman's shoe, maybe perhaps a woman is in the business world, has to wear relatively dressy type shoes, can't walk around with the type of walking shoes that we have now. That compression of the foot squeezes the bones together, the metatarsal heads, the nerve is trapped, and scar begins to develop around it, and thicken, until very limited pressure walking squeezes it, and oh, my toes are cramped. So were any of you to have checked off a yes on that, we'd say this is usually a problem that can be taken care of relatively simple, even as simple as a little insert with a little wedge underneath it. When you stand, when you put your foot into the shoe, you stand, you put your foot into the shoe, there's an insert with a little wedge that right in the right area that spreads those two metatarsals a little bit. It's a curved little wedge, painless, spread the head of the metatarsals apart so they don't press so hard. Simple. When that doesn't work, there is surgery, but the surgery is not devastating. You could ask Arlene, my wife. She had it several years ago. It wasn't too devastating. No.
Which time?
She, unfortunately, recurrences are very rare. Very rare. And when Arlene needed that foot surgery, naturally, I wasn't going to do it. You know, that. Certainly, I would not operate on any member of my family. That's just not a thing to do. So I found the very best surgeon I knew, and he was, to do the work. And recurrences are so rare that about one in, maybe, I'm pulling this out of the air, but I would say maybe 4 or 5 out of 100. So not rare, but certainly not common. Well, naturally, she was one of the 4 or 5 out of 100. Had to have it done the second time. But that happens to podiatrists-wise. You know, it's just the way it is. So let's go on to the next one. Is there a bump behind your big toe that gets irritated by shoes? A bump behind the big toe is a bunion. Bunion is a bone overgrowth that can cause most any shoe to rub, because shoes are not made with bump or space for bunion. Well, I'm going to see you haven't drawn a big toe for a while, so that's the nail. Now we can identify that as the big toe. And as we get back on the foot, right there, okay, and of course we've hopefully got other toes here, you know, okay, but here's the nail on the big toe, and right behind there's this bump, and that is a bunion. Anybody here ever see a bunion? Maybe on their own foot or somebody else's. I see some yeses. No, you know, we could have demonstrated, right?
Yeah.
Okay. So bunions are pretty common. And so again, what I tell you is a generality. I'll tell you what I used to tell my patients. All else being equal, meaning if you're in good health and everything's fine, don't have that bunion removed surgically unless it changes your quality of life. Okay? Quality of life means unless walking is no longer comfortable, if you're a woman, and they're more common in women, and your job demands that you wear a relatively conservative shoe every day that hurts, that's changing your quality of life. I used to say, you know, then you take care of it surgically. But nobody ever died of a bunion. Okay. So the bunion itself is a deformity. It's often inherited. Why does it occur? Well, our foot changes in life. It usually extends and flattens out somewhat, particularly if you're a woman and have children. Each time that symphysis enlarges so that the newborn can pass through, there's ligaments in the foot that stretch. So women say, my foot grew after this last pregnancy. It didn't grow, it just stretched, flattened out somewhat. So bunions are inherited, and they sometimes occur as a result of just walking on feet that have a tendency to elongate, and the big toe moves gradually over and the bump appears. But again, I repeat, nobody died of a bunion. But people have died out of complications of a bunion. Who are the people that get complications from a bunion? Diabetics. When you find a diabetic patient, when I say you, back to my teaching days, I see you as a classroom of potential almost podiatrists here. When we find a bunion in a diabetic, we don't say, live with it. We say, let's do something about it. Because particularly if you've lost some sensation, you may not be aware of the irritation. It's so common for a small sore to open up right at that apex of the bump, and from there, infection and so forth. So let's do something about it. So you say, oh, wow, surgery. And I say, the first thing we do about it is get you into a diabetic shoe. Okay? Now, even the federal government under Medicare recognizes that if you have diabetes and if you have a deformity, hello, that's a deformity, you qualify for a pair of diabetic shoes and 2 inserts. You qualify for payment of diabetic shoe, 2 inserts every single year. And those shoes with those inserts and different accommodations can give all the space in the world to the bunion. So anytime we find a diabetic patient with a deformity, be it bunions, or we'll talk about hammer toes, we'll talk about Taylor's bunions, that's that on the other side of the foot. Anytime we see a deformity in diabetes, we want to recommend strongly that you have diabetic shoes. And we'll answer any questions you have about that a little later. And certainly there are lots of opportunities, not opportunities, but locations in which you can purchase diabetic shoes. Now, I always recommend it. Unfortunately, just about anybody can become a diabetic shoe supplier. I mean, Medicare will give a supplier authorization to persons that want to open a store, for example, to sell diabetic shoes. There is no actual credentialing process as to how knowledgeable the supplier is that's providing you with diabetic shoes. We sometimes see pharmacies selling diabetic shoes. Pharmacists are great. I wouldn't want to live in an area where there were no pharmacists. But I don't want them to know about bunions and fitting diabetic shoes. So we always recommend that there are many, many podiatrists that do have diabetic shoes and provide them as part of their practice. And that is what we recommend for obvious reasons. The person that's prescribing and fitting the shoe should be very familiar with feet, and podiatrists are. There are also some specialty shoe stores that do have here in the area, that have qualified people. But they're going to need a prescription, usually from the podiatrist, in order for you to get that shoe. But I guess if I were able to say nothing more tonight than, hey, if you're diabetic and have any one of these things over here, make sure you find out about diabetic shoes. If I was not able to say anything more, I would feel that my mission was pretty much accomplished at that point. But naturally, I'll say more. So, let's go. I think we're down to the point where are any of your toes bent and irritated? And those are hammer toes. Those are toes that are kind of cocked up. Why they got the name of hammer toe is that very often the end of the toe is like hammering away at the sole of the shoe. When the toes should be straight out, they're crooked and bent, and the ends of the toes can be touching the walking surface. And that is sometimes called a mallet toe, hammer toe. Those are very, very much responsible for irritations, corns, just a hard skin area that ulcerate. There again, if you have hammer toes, we've got to do something about it. Be it a shoe that you wear all the time that doesn't allow irritation to happen, or maybe surgery. After all, these surgeries done at a time. It's not a hospital inpatient situation. And nowadays the techniques are such where there's really not a lot of suffering involved, except if my wife were to have another one. I'm sure that would be definitely some suffering. So if you have hammer toes, don't keep them. Well, keep them if you're paying careful attention to shoes, but otherwise, let's have them corrected. Let's go on. Do the sides of your nail grow into the flesh? Well, I'm going to draw another one of the pictures of it.
But that's because you keep them pet.
If we look straight on at the end of the toe, straight on, end of the toe looking at me. I'm looking straight on at the nail, okay? And beneath the nail there is bone, kind of looks like this. And then there's toe. So I hope that makes sense to you. This is the nail, looking straight on, bone underneath it, and then the fleshy part of the toe. Now, in some people, as we get older, that nail begins to curve like that. And there's the toe. And in some, it actually not only curves, but almost angulates in as if to trap you, and looks like that. So the nail can change its shape somewhat as we get older, and the sides can embed themselves in the flesh, and that makes it very, 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 it makes a situation in which you're very, very prone to get pain from an ingrown toenail. The nail is curved like that, and it shouldn't be, and it's kind of embedded in the tissues. Now, that wouldn't be a good thing in itself, but what makes it worse is it's extremely hard to cut that toenail straight across. How should we cut our toenails? Straight across, not curving with what? With a toenail clipper, not a fingernail clipper. Worst thing you can do is use a fingernail clipper. It leaves pointed ends because it's not as wide as the nail. So in the pharmacies you can get a toenail clipper. That's better, certainly. Or if you're diabetic and doing the best thing for your feet, you're getting attention to your feet by a podiatrist who's going, especially if you have that kind of a nail, because it's so prone for it to be cut incorrectly and infection to start because the nail is embedded in the tissue. Any question about that in particular? Yeah.
What happens when you have that condition combined with the thickening?
Combined with, I'm sorry, I didn't get the
The
last.
thickening.
It makes the likelihood of irritation greater. There's more pressure by the shoes, and so the likelihood of you having a lot of pain from it is greater. And the risk of something happening in the way of the pressure causing an open ulceration or just enough irritation to cause some infection is greater. So a combination of that nail with thickening is worse than either one of
Does the
those.
fungus cause that too?
Oh, no, no. Fungus does not usually cause the nail to involute, as it's called, to change its shape in that way.
I
No.
just happen to have all in the same toe.
It's like you have two different problems coexisting in the toe. Lucky you. We could use you for demonstration purposes. Okay. The next one, I think, is coming up is, do you have corns or calluses? Well, the difference between a corn and a callus is just where is it located. What's a corn? Well, a corn is on the toes or on the side of the foot, but not on the bottom, and it is caused by friction and pressure. Now, if you have a shoe, for example, that every day rubs, not a heck of a lot, but enough, you're aware of it, and then you're not aware of it, but every day you're wearing that shoe, sooner or later nature will thicken the skin as a protection. But the irritation continues, so the thickening continues. And before you know it, you have a hardened area, the same as, well, if I was shoveling coal as they used to do back in childhood days or today, doing some labor, with my hands shoveling, I'm going to develop calluses on the hand from the handle of the shovel. No matter gloves or whatever, sooner or later that friction, every single day or whatever it is, often enough, causes that skin to thicken. So calluses on the bottom of the foot, corns on the top, both really the same thing. But again, we have to find out what's irritating the toes, either by the right kind of shoe that will no longer irritate it, or by correcting the toe we can get rid of the corn. Calluses are usually a sign of some mechanical problem with the foot, meaning that you're not bearing weight evenly on your foot. That too much weight is either on the inside of the ball or the outside of the ball of the foot or in the middle of the ball. Too much weight is being transmitted through a small area. And that can happen for different reasons. There are 5 metatarsals in the foot, sometimes because there's arthritis in the joint down in the middle of the foot. One of those metatarsals, often the second metatarsal, will just get lower, protrude downward in the foot. That bone, that joint's a little lower. You can actually look at the bottom of the foot and see, hey, there's a little prominence over there because that bone is lower. Well, when you walk on that, that lower area picks up all the pressure, doesn't it? You know, walk on it, picks up the pressure, callus develops. So what do we do about it? Well, if you had that, I would give you 2 choices. We can make an insert, put it in your shoe. It has a depression for that area, and it forces your foot to bear weight on other areas, and we would take it off. Or we could tell you, hey, we can go in surgically, and we can lift that bone up, fix it, and have it heal so you wouldn't have to wear inserts. But you'd have a choice. And most people really will say what I think they probably should say, and well, let's give the simpler way a chance. And very often, that's fine. Some people can't do the simpler way. Some people simply want to wear the shoes they want to wear. They don't want insoles. They don't want to. These are people that don't want glasses, don't want contacts. They want the surgery, that they don't need anything. And some people choose, well, if I can get rid of this, I want to do it. And there's nothing wrong with that. So, except if you're diabetic, of course, we got to think twice about that surgery. And I would say the doctor probably going to advise you, let's try the simpler way first. Okay? So, the next one, which is probably one of the most important things we'll talk about. Do you have unusual sensations like tingling or numbness? Tingling, numbness, feeling of bugs crawling, a strange feeling, but a common feeling. Just abnormal sensations. Do you have those? There's another question that I wish I could ask, but it doesn't make any sense. And it's the most important question of all, which you can't answer. Do you not feel your feet? Do you not feel the bottom of your feet? How are you going to answer that? Well, I don't know if I don't feel it. I mean, if I have pain, I know what pain is. But if I don't have feeling, how do I say it? Well, unless you've tested yourself, or you've recognized, hey, wait a minute, I can scratch the bottom of my foot, I don't feel it at all. Maybe you've done that. Then you could answer that question. But most of us, no. We can't. And that's why the Las Vegas Summerlin Lions Club and the Leap Alliance, we've partnered. We go all over the city of Las Vegas. And we have the commendation of the Las Vegas City Council. And tomorrow we meet with the mayor. And because we have a program called Lions Hunt for Diabetic Peripheral Neuropathy. Diabetic peripheral neuropathy. Many of you are all too familiar with that disease. Simplified. This is so simplified for those of you that are not familiar. High blood sugar. Nerves don't like that. They just cannot metabolize the sugar properly. The proper nerve function is often impaired with persistent high blood sugar. And one of the first things that happens is the nerves that are responsible for feeling lose their ability to transmit, I'm feeling something, to the brain. They lose their ability. So that, here's a couple of examples. There's a little pebble in your shoe. And you're walking around with the shoe all day long. Anybody else would take the shoe off and get rid of the sharp pebble. It's kind of like a pointed thing. I don't feel it. At the end of the day, take it off. Maybe don't do what every diabetic should do at the end of the day. Feel the bottom of your feet. See if there's any warm spots. Warm spots are warning spots. There's inflammation. And they got to do something about it. If at the end of the day of walking on a pebble, I would sit at the bed and not easily bent down, but bend down and let my palm of my hand run down the foot, I'd feel, oh, wait a minute, this is warm. And then I'd feel, wait a minute, there's something sharp there maybe. And maybe the pebble is in the foot, maybe it isn't, but look for warm spots. In this case, that pebble could have opened a sore. The sore can get infected. The infection can spread. Amputation could happen down the line if proper care isn't given to that. But the fact is, why did it happen? It happened because we've lost protective sensation. It's called LOPS, L-O-P-S, loss of protective sensation. So the Lions Hunt for diabetic peripheral neuropathy simply means we go to health fairs, we train you to how to do your own, we go to health fairs with filaments, which I'll show you momentarily, and we do tests for loss of feeling. We tell our families and our friends how to use a simple, looks like fishing line, Semmes Weinstein monofilament. We teach people how to use a Semmes Weinstein monofilament on someone's feet to find out if that someone has lost sensation. Such a simple test saves limbs and saves lives. After an amputation, the survival rate is lower in breast cancer surgery, prostate cancer surgery, lower than in a person that has lost a leg. Their life expectancy is lower than others with severe cancer surgery. So we don't want that first ulcer to appear. We don't want that first infection. We don't want the first toe amputated. Simple filament. And the government has a whole website. I'm sure Chris is very much aware of the LEAP website, Lower Extremity Amputation Prevention. That's the government program. We're the LEAP Alliance. And we want you to learn how to use this yourself. We want to screen you. We want you to tell your friends, because that's the Lions Hunt for diabetic peripheral neuropathy. And that is basically what we wanted to say about your unusual sensations, because usually with the unusual sensations, there's loss of feelings, and that seems like paradoxical or doesn't seem to make sense, but that's often the way it is. If your feet are always cold, it could be because blood supply to your feet is impaired. Much more common in diabetes than in those that don't have diabetes, because the plaquing of the arteries seems to be not encouraged, but in diabetes, the metabolism, the altered metabolism of glucose in diabetes seems to enhance or promote the formation of plaque within the arteries. And so we also promote the testing of pulses, very simple, by your physicians. Every time you see your physician, by the way, just sit in the examining room waiting for him or her with your shoes off. I mean, that's a must, you know. And make sure that you get your circulation checked, but particularly if your feet are feeling cold. Now, I'm from Chicago. We used to have some humid summers there, and people rarely complain of dry feet during the summer, unless they had some cause other than humidity and lack of it. Now here in Las Vegas, in our area, dryness is the rule, not the exception. So it's quite usual to have dry skin problems. That makes it a little difficult to recognize at times whether the dry, scaly bottom of feet, is due to just dryness or due to a chronic fungal infection by a particular organism, T. rubrum. There will be no test after this lecture. You don't have to worry about remembering that. But there is a chronic fungus infection of the foot that basically attacks the plantar surface, the bottom surface, dry and scaly, Heels often fissure, cracks in the heels. If you recognize any of those signs, there's a good chance that you're harboring this organism, and that's relatively easy to manage and treat, because topicals not topicals meant to grease or lubricate, but topicals meant to kill those fungi that are living in the outer layers of your skin. Those topicals can usually change your feet regardless of humidity, because that dryness doesn't have anything to do with humidity. Okay, so, do you have any painful growths on the soles of your feet? Well, this is kind of when we were all younger, we were prone to plantar warts. As we get older, we seem to develop a resistance to them because they are caused by a virus, and most of us have an immunity. So it's very unusual to see a person over the age of 50 with warts on the bottom of their feet. Now, sometimes we develop different kinds of warts on our skin, other than the bottom of our feet. Now, plantar has nothing to do with farming. People would say, I don't know, I've been told I have, a patient would tell me, I've been told I have a plantar wart, I've planted nothing. And I smiled, because it was only the 10th time that day I heard that, so you have to kind of force a smile. Well, actually, plantar means the bottom of your foot, like palmar means the bottom of the surface, this surface of your hand, so it's the bottom or sole of your foot. So plantar warts are very uncommon, but they can occur, and they are likely to be on areas where there is no weight bearing, meaning that a callus will form where you bear weight on the heel, on the ball of the foot, but a wart will often form on the arch, which really isn't in contact with anything. And then again, you might look at the bottom of your foot and say, I think this is a wart, it's not too important. We don't really know if it is a wart. Any growth on the bottom of your foot or anywhere on your foot or elsewhere should be looked at. You know that. I don't have to tell you that. Don't leave any growth anywhere unexamined. It's just important that we know what something is. Do your arches ache when you're on your feet a lot? Well, I think that we have to answer the question, what's a lot? I can take any person, no matter what their age is, and not let them sit down and continue to walk and walk and walk. Maybe some can go 2 days, but eventually their feet will hurt, and their arches will hurt. And as we get older, of course, nobody wants to walk continually for a few days, but even short distances can result in pain in the feet. I just repeat what I said earlier. Feet don't have to hurt. Usually simple meaning that the making of an insert to distribute weight better, to take pressure off of your feet, usually that will do the job. It's kind of like eyeglasses. Once you get the prescription and you put the eyeglasses on, you see well. Once you figure out which joints are being overstressed and make an insert that you can put into your shoes, you put the shoes on and say, gee, I can walk now. So, people say, what about these kiosks and Walmart and so forth? They have these orthotics for $50 or whatever they are. And I went to a podiatrist, and the podiatrist wanted $200 and some. Should I try the ones from Walmart? Well, why not? Why not for this reason? Very often, it is not difficult to bring relief, and that's all you want is relief. We're not trying to take your arch and make it high by any means. We're trying to give you relief from pain. And nowadays, some of these machines that you step on, and Dr. Scholl, whatever, give you a close approximation of enough wedging and raises in the right areas to relieve pain. So it's kind of like we're in Vegas. It's a kind of a gamble of maybe $50. If you go right to the podiatrist, yes, it's going to cost you more. Well, first of all, your first visit, if you have Medicare, or if you're referred by a gatekeeper, we used to call him a family physician, an HMO, that first visit should be covered. Orthotics may or may not be, but they are much more expensive. But they're made usually one of two ways, over a model of a foot. So, President, I think you may be calling for me. Anybody want to check? Sorry. We have, so if you want to gamble, the price of those orthotics, they may do the trick. On the other hand, if you want to go straight to where you're likely to have the best results in the most direct way, that's going to be to go to your podiatrist. Okay? Do you have now or have you had slow healing sores on your feet? Well, I think in this group, you may have had slow healing sores on your feet, and presently, hopefully, you don't have them anymore. The best thing we can advise is that you have your feet checked regularly, and most regularly by you. Check your shoes. Make sure there's no wrinkles in the shoes. Make sure there's no red spots on your toes. Make sure there's no hot spots on the bottom of your feet. Get a simple foot powder that you can that will absorb perspiration, because perspiration causes rubbing, and rubbing can cause irritations. There are simple foot powders. I happen to like a foot powder called Zesorb. Zeasorb. It's been around a long time. Zesorb. The thing that makes it so good is it absorbs about 10 times its weight in moisture. So you sprinkle a little powder in there, it absorbs a lot of moisture. You don't want friction, you don't want rubbing. Some foot powder. And so that's actually the most important thing. If you have had an ulcer, an open sore, you don't want another one. If you've never had one, you don't want the first one. Check your feet. Sometimes it's hard to see the bottom of your feet. It's great to have a support person. You know, they do sell mirrors, by the way, on handles where you can see the bottom of your feet. But definitely take advantage of the free foot screenings that are available. If you'd like a sheet that tells you where they are available, we have them here. If you feel that, come again, it's one of these. If you feel that you may have lost sensation and want a quick checkup, and I hate to do quick checkups, but we can use our filament. We don't penetrate, it doesn't hurt. There's no need for gloves or anything. There's no transmission of nothing more different than shaking hands, you know. We can see if you feel the filament. And if you want to stay, we'll be happy to do that.
Can I ask you one question?
Sure.
That will help the whole group? If anyone in here has any type of trauma, how quick do they need to get into a podiatrist after suffering some kind of foot trauma, maybe on a weekend or something? When's the soonest they should get in to see their podiatrist?
Let me hesitate for a moment. If the trauma was enough to be considered an injury, I mean, I might just bump my toe, you know, but let's put it this way. If there has been any trauma that you even suspect could cause a problem, the answer has to be immediately, if not sooner, get some attention to it. Immediately, if not sooner. Trauma, because you use the word trauma, does mean that there's an injury worthy of paying attention to.
Thank you.
What about diabetic socks? Do you recommend diabetic socks?
Diabetic socks are still in the investigational stage, but all the information that we see points to them being effective in preventing problems. They are usually made with metallic elements in them that have an inhibiting capability for fungal and bacterial infections. Yes?
Going back, you were talking about shoes and checking the inside of your shoes. Just looking at the group here, not including Chris, because he's, you know, a baby. But one thing you should talk about is slippers. Because people change their shoes frequently. But how many people have the same slippers day after day, year after year, especially men?
That is a wonderful suggestion.
Yes.
Slippers, yes, you're absolutely right. And not only that, let's talk about one little other item. Little, it's not little. Let's talk about falls. 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 When you look statistically, I don't have my statistic book down here. Sometimes I think my mind is kind of like Teflon, nothing sticks lately, you know. If I knew the statistic, I might have forgotten it. But there is actually such a very high incidence of serious injuries resulting from falls. And one of the most common causes of fall is what? Diabetic peripheral neuropathy. Why? Now, we happen to be at the police, Lions, we're at the Metro Police Department health fair for the police and their families. And one of our members, Brian Werner, is a physical therapist that specializes in balance. And he had a highly sophisticated machine that to check your balance, you step on it and it's making measurements and it tells you whether your balance is normal or not. So a woman got onto the machine and she was looking perfect. All the stats that were coming out, because he asked you to do certain things, everything was perfect. Looked like she had no problem. The last part of the test is, okay, now please close your eyes and let's see how you do. She closed her eyes and somebody had to hold on to her. Why? Her brain was depending on her eyes and body messages for balance. And once she closed them, her eyes, it depended on her feet to know where she was. Because that's one of the things sensation in our feet does. It tells our brain whether we're standing up. She had lost sensation in her feet, and for that reason, when her eyes were closed, she had no balance. When we walk, we blink. Something gets into our eye, or momentarily, and each time that happens, we lose an element of balance. So, yes, walking in slippers, you can lose your balance very easily. Check the slippers. They often get caught in carpeting. That's a problem. But it reminded me to tell you about loss of sensation in the bottom of the feet and why we got to be concerned about falls. Yes?
As a follow-up to that, I thought that when you close your eyes, in addition to your feet, that you also would be having to do with the balance in your ears.
Yes.
That also cause
True,
that.
true. That's true. Not being a neurologist, I'm going to just say, generally speaking, balance is the sum total of a lot of receptors, to the brain. The brain receives a lot of messages from different locations. Sight is one of them here. But a very important one is knowing where our feet are. And so that's true. There are many signals coming to the brain.
But you got to remember, when one nerve has a problem, many nerves have a problem within the body. So diabetes does not only affect the nerves in your feet. By the time you have diabetic peripheral neuropathy, you may have other neuropathies. One neuropathy follows another. Therefore, maybe your receptors within your semicircular canals in your ears, your eyes, when you close your eyes, when you can't feel your feet, when your lack of touching, if you don't touch or grab onto a bar in the shower. So somebody who's in a shower closes their eyes, lets go, they probably are going to be falling in the shower. And just like Dr. Rubin was stating.
And your comments also applies, I'm very glad you mentioned that, not only to nerve diseases, but to arterial problems. For example, if the circulation in your feet is poor, don't expect the circulation in the heart or brain to be a lot better. So sometimes we get the warning signs in our feet and we check for problems there, but it can alert us to referring patients for further testing of the cardiovascular system.
These old-time remedies. Where can I find your C-Sort?
Our drug company is Steifel, S-T-E-I-F-E-L, and we get it regularly. We use that. Smith's Pharmacy has it, I'm sure.
Pharmacy.
Yeah, and it actually comes in two types. There's the Z-Zord AF, antifungal. That's the one you want, because it does you no harm to have something fighting off those fungi.
No.
Anybody on this side got a high gun? This is the side, I'll tell you, here's where the questions are. Yes.
At night, when you're sleeping, when you get up, if your legs or feet are stiff for like maybe the first, maybe 15, 20 seconds that you're walking, is that a sign of something?
Yeah, actually, it's kind of a modification of the heel pain.
Yeah, it's
What
not,
we talking
not
about?
heel, it's just that.
Right,
that there's-
but you say your feet are stiff and they kind of hurt a little bit.
But it's not tingling, it's not
No,
numbness.
no, no.
It's just like walking on blocks of wood.
Yeah, well, usually, and again I have to say usually, that means that the joints have been stressed and are inflamed to some extent. So you may be walking around with some sore feet.
It's very short-lived though, it goes away
Well,
in like 10, 15
That's
seconds.
usually the way that heel pain works too. It usually is a sign of some inflammation, probably just due to strain. And if, it may be something you want to look into, because sometimes some early arthritis can cause that. We have a question there.
Yeah, going back on here, when you talk about the thickness of the toenails, which are fine, my daughter has had both knees operated on, and she's 45, so she's more relevant to us than to others. But I have noticed that her toes seem to be blue a lot of the time, which to me says that she's not getting circulation in the feet.
Okay, it's not in a 45-year-old. When we see some blueness of the toes, it's something we want to look into. It doesn't necessarily mean that it's something so terribly serious that we go right now and pick up the phone. But it's something we want to look into. And there are some common causes. One of the common causes seems to be more prevalent in persons that are very active and very focused, very concentrated. Okay, I'm getting a no on that. And the reason why that can occur in that type of person is because they're often prone to neurovascular changes, meaning that kind of the opposite of blushing, there will be some vasoconstriction as a part of the metabolism of the hormones of stress, some narrowing down of the little vessels that feed the foot, and particularly the toes. There is a condition called Raynaud's syndrome, and then there's a disease called Raynaud's disease. And they kind of fit into two similar categories of these diseases that are autoimmune. So, it's something that you should look into because it may be a sign of some other problem. And she may be able to focus on some problem she may not even be aware of. So I would have it looked into. Probably some simple tests. I mean, anemia, there are a lot of different situations, but hopefully she would check out fine. And then we call that disease idiopathic. It is idiopathic blueness. What does idiopathic mean? We don't really know why.
Does anybody have one more question for the doctor?
Yes.
I have a problem that periodically, maybe once a month or twice a month, my big toe gets cramped and it comes straight up like that and it will not go down. I have to manually make it go down. Is that caused by something in the nerves doing that? Or?
Well, if we were going to kind of give it everyday language, we'd say it's a Charlie horse of the muscle that controls the great toe, which is the extensor muscle that controls that great toe. Something has triggered it into spasm. Okay, it's unusual for one toe alone to do that, but there may have been some injury to the muscle that might have been even some time ago, where it's very, very fragile. And but how often does it happen?
It's the same foot.
But how often?
And how often? Twice a month.
Twice a month. What are you doing when it happens? Are you doing anything?
I can
But-
hardly bring it back down to normal again.
But are you doing anything at the time, like walking, sitting? Oh, sleeping.
I wake up and when I'm in the middle of the night, I got
cramp?
This is called heavy dreamosis. I'm kidding. I don't mean to make light of it, but we do move in our sleep. And it is possible that what you do in moving is you stretch the toe back, and that triggers the muscle to, or stretch the toe down in motion, because that can do it too. And then there's a condition called restless legs, which is sometimes associated with diabetes as well,
I have that.
in which there's no place to put your legs and feet, and that's kind of a different thing. But something's happening to trigger off that muscle spasm, and it's usually that the toe has been, in sleep in this case, moved down or up.
Dr. Rubin, we have one more, and then we're going to have to call it quits for the
Okay.
night because the time's
Just
getting past us.
Quick question.
Sure.
I used to get frequent gout attacks.
Yes.
However, the past couple of years I've been diabetic. I haven't had any. Is there any relationship with diabetes and gout?
Well, there is relationship of frequency and some of the metabolism of gout and diabetes. These are two diseases that don't go well together. Are you on medication now? There's a lot of good medications for gout.
I haven't had an attack in years.
Well, the question is, the next time you're examined by your physician, suggest a uric acid test to see whether you're at risk of having these attacks. If your uric acid is normal and you're watched for it, doesn't seem to be a problem.
Thank you.
Thank you very much. You've been a great audience.
Dr. Rubin, thank you on behalf of the Gibbs. We thank you very much. And if anybody wants a monofilament test, he'll perform or can perform a couple of those. And if you don't mind being filmed, we're going to do that so that it can be part of this YouTube video. And we will get the YouTube video up. Thank you, Dr. Rubin. Adem's thanks you.
Thank you for asking.
Are we ready? All right, so just tip your foot up so it's like that. There we go. All right, it looks, close your eyes and then just make sure you tell me yes when you feel it, okay?
Oh, I see. Yes.
Okay.
Yes. Yes.
Feel that?
Very faintly, but I did feel
Okay.
it.
All right, and there's some, maybe a callus area there too. So.
Yes.
Okay. Yes. Okay.
Yes. Yes.
Okay. You have very good feeling in your feet. The only time there was lag was here in this callus area. So otherwise, it's good.
Okay.
You should just check it every year, but right now it's very good.
Okay.
Good. All
I
right.
was going to show him that little toe and that big toe. I was having trouble with those.
Yeah.
Okay. All right.
Which do you want?
I don't care,
You want the
Bill.
one where I'm
What?
missing a toe, or you want the one that's
I
really
don't care.
good?
Whatever you want to do.
Yes, your husband will just, oh, he'd say, oh, look at this toe.
No, that's not my husband. That's Arlene's husband.
Oh, okay.
Okay. I'm going to touch various points on your
Yes.
feet.
I've had it done
You
before.
had it done before? Okay.
Not for the last few years.
Sorry, so don't look at that. Look over there. So, and then say yes when you feel it, okay?
Okay.
Feel that?
Yes.
That?
Yeah, just a little pressure.
Yeah? That one?
Yes.
All right.
Yes.
Okay. How about that one?
Yes.
That one?
Just barely.
Just barely? Okay.
I'm sure we don't want to terribly close here.
No?
Yes.
Okay.
If you've got your stalls for me,
That one?
Yeah.
I do some
Yes.
screening work
Okay.
at the Lions Club in the Summerlin Hospital Medical Building. Is that you?
Yeah. Sort of pressure.
Some pressure? Okay.
Yes.
All right. So So the areas that are like on the toe here, you said you felt pressure, but you didn't really, you felt something touching.
Yeah, I can feel, I mean, there's a difference. I mean, there's sort of a deep feeling of very light pressure
Okay,
and versus, you know, a definite point sensation
yeah,
on other places.
yeah,
So,
yeah. Well, you know enough to have it tested if you begin to feel it, just, you know.
yeah,
Okay,
yeah, I'm getting diabetic shoes for podiatrist. When they call me. But yeah,
yeah,
I have, I mean, you can see that my foot
yeah. But otherwise, you have
seriously
sensation.
messed up.
Yeah, but you have other areas that are, you know, otherwise you have some good sensation, and just in one of those.
Yeah, I mean, it's, right up here is the main part.
Yeah.
And it's, the sensations are kind of strange. And then right here, I get burning sensation.
Yeah,
So, I mean, if I'm walking for a while, I get some burning sensations. If sometimes it just burns,
yeah,
and sometimes it does, and most of the time it doesn't.
yeah.
But I mean, you know, if I'm on my feet for a long time, I get this burning.
Does it go away when you get off your feet?
Yeah, not always. It's usually.
Yeah,
So, and I mean, you know, it doesn't do it all the time, but it does do, you know, I mean, sometimes it just comes in out of the blue.
yeah,
And sometimes usually it will occur after I'm on my feet for quite a while.
yeah.
I mean, I know it's neuropathy.
And you know, because you take care of yourself, you're diabetic, you take care of yourself.
Yeah,
So, and you have to do that.
yeah. Yeah, I mean, I can feel the difference in texture, you know, between this and this.
And that, okay, yeah.
There's a very different feeling.
Yeah. Okay.